let's start with Section 1, Growth and Development. In this section, we're going to review characteristics of development, lifespan development of the infant, the toddler, the preschooler, the school-aged child, and the adolescent. So let's begin the review in Section 1 with growth and development. Now, there are a couple of characteristics of development that we need to keep in mind, and this will be something that will be a foundation for you to remember throughout the pediatric review. And that is that growth and development starts as a proximal distal process from close to near, from the body out, and also that it's cephalocaudal or head to tail, meaning that a child, for example, will hold their head up first and then walk later. Now, let's move on to lifespan and development of the infant. And you'll notice that, keep in mind that infancy is birth to 12 months of age. The key things to remember about this group is that their height will increase by 50% in the first year. Also, their weight will double by 6 months and triple by 1 year. This will be a key question that you are very likely to see on your exam. For example, an infant is brought to a clinic to be weighed and evaluated. You'll be given the birth weight, and you'll be determining, is this an appropriate weight gain for this child at a certain age. Also, with head assessment, the anterior and posterior fontanelles are important to remember. That the posterior fontanelle closes by 2 months of age, and that the anterior fontanelle closes by 12 to 18 months. And don't forget, also with fontanelle assessment, those two key things, a bulging fontanelle is indicative of increasing cranial pressure, which you may likely be evaluating with children who have hydrocephalus or other neural tube problems that we'll talk about a little later, and also a sunken fontanelle, which is a classic sign of dehydration, which we'll discuss a little more when we talk about gastrointestinal difficulties. Now, when we talk about teeth in the newborn, or the infancy period, we're not doing a dental exam, so don't worry about when each tooth erupts and when and the age and where. The main thing is to know that a child has an appropriate number of teeth for age. And a key thing that you can do to keep that in mind is to take the age of the child in months, subtract 6, and that should be the approximate number of teeth that child should have. For example, a 12-month-old, subtract 6, should have at least 6 teeth. Now, of course, there might be 5 or there might be 8, but they're in the ballpark. And also that by 2.5 years, they should have all of their primary teeth. And then, of course, dental care should start as soon as we have teeth. Brushing teeth and then seeing a dentist by at least the age of 2. Now, interventions, when we talk about infants, nursing interventions with teeth are very important. Remember that dental care, we only have one set of teeth, and we want to promote that health just as much as we do other aspects. So medications are going to be important to remember when administering medications or doing your education with parents, to avoid medications that stain the teeth, or at least how to administer them correctly. Tetracycline and iron are teeth staining medications, and that Dilantin causes the gingivitis, the hyperplasia, just like in adult patients. You will see that in children. So remembering good dental and oral care and education will be key in this area. Also, being able to identify you'll have probably scenarios in your questions that will talk about the baby is starting to teeth, is fussy, what should they do, how will they know that this is happening. Increasing in drooling, finger sucking, chewing, those kind of things are the classic signs that you'll see in your questions that indicate that teething is starting. Interventions that most likely in a question you'll be asked to give educational interventions to a parent about this would be cool or cold items, teething rings, Tylenol for irritability on a limited basis, not constantly, but for those high peak times of fussiness. And then key thing this goes in with nutrition as well as oral hygiene, is that once tooth eruption starts, the nighttime bottle needs to either be water or nothing, but water would be acceptable, but no juice or formula, because the sugars left on the teeth will cause cavities. Now, as you see next, we have this on your screen, we talk about reflexes. Now let me show you something here that will help you to remember your reflexes, your infancy reflexes. We have rooting, tonic neck, Moro, all those classic reflexes that you have assessed in your clinical area, seen how they are elicited, and you're thinking to yourself probably, I will never remember when these come and when these go. You will see that they all disappear by 3 to 4 months of age. Look at things in huge categories, commonalities. That's helpful when you get to the exam, that you can remember things, because you'll be a little stressed and you'll be afraid that you'll forget something. So remember that your infancy reflexes, all but the sucking reflex, disappears by 3 to 4 months of age. Now, sucking reflex will continue through 12 months, and that's how long we want infants drinking a bottle or breastfeeding. So that makes sense that that would go together. So sucking through infancy, or the 12-month period, and everything else should be disappearing by 3 to 4 months of age. When we talk about the infancy period, vital signs are drastically different than what you're used to with adult patients. And as we go through the review, you will see that vital signs will, as we go through each developmental period, will drop by 10 to 20 beats or breaths per minute. And then when we get to adolescence, they will be more like the adult vital signs. So that will help you in keeping in mind when you see a particular developmental level that you're being asked a question about, you'll be able to recall your vital signs. Don't commit numbers to memory. Think conceptually about these things. So with infants, in your nursery rotation, you've assessed infants and you've seen that they have that high heart rate, 100 to 140 beats a minute is considered normal. We see the 100 more when they're asleep or still, and that can be as much as 180 or 200 when they're crying and fussy. Respirations ranging from 30 to 40 beats a minute. Also remember the infant has an immature thermoregulatory system, and we'll talk more specifically about that with our newborn in our OB section. But they are more prone to cold stress, and crying will increase their vital signs, obviously. Now, moving on to nutrition, this is a key area that you need to focus on with your review of infant developmental period, because nutrition is key to growth and development. It is an inhibitor of growth and development, and it's also a promoter of growth and development. So you are very likely to see a good number of nutrition-related questions about infancy and childhood. So this is an area that you would want to focus on. With infants, with this developmental level, we want to be sure that the infant sets the schedule on demand. And breast and bottle feeding is going to be up to the mom, but whichever method is used, that the infant sets his own schedule. With breastfed infants, vitamin supplementation, if the mom has good nutritional habits, may not be needed. With bottle-fed infants, it may. Also, the fluoride supplement was the key item to remember with breastfeeding infants, is they will need the fluoride because they're not getting the fluoride from water. Then introducing solid foods. This is a very common question that you will see parents will ask. The question will be set up to parents will ask about when can we feed this, when can we feed that, and you will be providing that anticipatory guidance or education answer. That's what they're going to be looking for. So with infants, introducing solid foods needs to be after the tongue extrusion reflex has gone away, and that's around 4 months. They also need to have good digestive enzymes developed, have the motor skills to eat solid foods, and have an interest. But the guidelines that you need to keep in mind is that usually between 4 to 6 months of age is when the newborn or the infant will start to eat some type of solid food other than breast milk or formula, and to introduce foods one at a time so that if there is an allergic reaction, the food can be identified and eliminated. If you introduce 2 or 3 things at once, it's very difficult to determine which one is the cause of the allergy. And then, as you see in your box here, the sequencing of the food. And you'll very likely have questions which will give you the age of the child. They're going to introduce food, what's been introduced, what comes next type of question, and this is how you can remember it. The rice cereal goes first because it's the least allergenic of the foods, and it's also very high in iron. Fruits and vegetables are next, then meats, and then egg yolks, and avoiding egg whites. But they should be given by at least 15 months of age because of the MMR immunization that the baby will receive then. So remember, rice, fruits and vegetables, meats, and then egg yolks. Then table food can begin about 8 to 12 months. The key thing to remember here is that we want to encourage the parents to remember not to give foods that are high aspiration risk, things like nuts, raisins, hot dogs, those kinds of things that are easily aspirated, because the baby is learning to eat. They're not a professional at it yet. They're learning, so they need to have low aspiration risk foods. Another key item to keep in mind is that infants do not have whole milk until 12 months of age, because they do not have the digestive enzymes to handle that. And as they increase their solids, they will decrease their milk, and that will decrease their risk for iron deficiency anemia. Remember, milk is a poor source of iron, and once they lose their iron stores, they need to get their own sources of it. Weaning is also an important question area, again, educational type question that you're very likely to see, that by 12 to 14 months, the baby should be weaning from the bottle or the breast and drinking from a cup. This can begin around 4 to 6 months along with the introduction of solid foods. And removing the least comforting feeding last. The bedtime usually is the one, but to gradually the least interesting feeding, take that away first. And then weaning should go fairly smoothly. And then one other thing in relation to nutrition before we move on is some nutritional concerns. Colic is one that is likely to be seen on your exam. Some key things to remember there is that colic usually occurs in infants of 3 months of age or less. And this is where they have the abdominal pain, the long-term crying. It's usually at a certain period or time during the day. The infant isn't comforting very easily, and the parents are very distressed by this, thinking that something is wrong with the baby. Most of the time it's related to overfeeding, inadequate burping. They have a lot of air trapping in their stomach and gas. So interventions or education that you would be asked to answer about would be things like being sure to be giving extra TLC and comfort, avoiding feedings, excessive feedings, frequent burping, maybe positioning the baby in a more upright position, and then being patient. And remember that colicky babies are very frustrating, and so keep your eyes open for a question that may say something about risk for abuse or something like that, but most likely it will be about techniques to decrease the air trapping. And then the second nutritional concern for this age group is iron deficiency anemia. Now, if you'll recall, baby will have iron stores from mom up until about 5 to 6 months of age, and this is assuming that the baby is term and the mom has had adequate nutrition during pregnancy. But those babies that are born prematurely, or mom has had poor nutritional habits, perhaps has been using drugs, using alcohol, those are high-risk patients for not having good iron stores. So keep that in mind as well. Where the red blood cells are very small, they don't have good oxygen carry capacity, so the baby will be pale, may have increased respiratory rate, trying to bring in more oxygen because the body is responding to that need. And so they will be giving Thiazole, the multivitamins with iron, those kind of things as a treatment for it. Interventions, client education that you need to focus on when working with parents and giving iron to a baby is it needs to be administered between meals, because we know that the absorption is best on an empty stomach, and also with a acidic beverage, so their juices, their orange juice or something like that would be a good choice. And this is going to be in a liquid form, obviously, so they will need to use a dropper and then rinse behind with some water or something so it doesn't stain the teeth. And a very likely question is how you're going to measure compliance. How's this happening? We don't want to stick the baby constantly for hemoglobin and hematocrit. One of the ways that we can determine that the iron is being given is that the parents report the tarry stools, or the darkening of the stools. Also, that iron may be a little constipating, and that might be something that you see on a question that the parent is telling you about. Now, we're going to move out of nutrition and move on to activity and rest. And infants sleep 14 to 16 hours per day normally. We don't know which 14 to 16 hours, but they do sleep 14 to 16 hours. And their nighttime patterns usually fall into place where they are night sleepers a fair number of hours at night, around 3 to 4 months of age. Also, motor skills are important, and this is going to be very important in assessment of developmental milestones being achieved, growth and development. And infants, starting in the beginning of infancy period, will have motor skills and certain abilities that you want to assess to be sure that they're having good growth and development. Now, you will notice here in the next several items that there are many motor skills listed. What I'm going to do is give you, I know that you have reviewed in your nursing program all of these skills. You've probably gone and worked with infants in a daycare center, in a pediatric unit, where you have had to observe all of these growth and development, motor skills, and those kind of things. I'm going to give you the key motor skills that are most likely to be seen on a question to identify the age of the child and are they at appropriate growth and developmental level. And so if you would, go ahead and just take your pen and be ready, and I'm going to tell you which ones are key, and you can just star those or highlight those so that you can kind of get the feeling of where that's going to be. With a 2-month-old, the most likely thing that you'll see as identifier for them and their motor skills is that they smile socially. With a 3-month-old, they reach for objects. With a 4-month-old, that they roll from back to side. 5 to 6-month-old rolls over completely. 6 to 8 months sits alone, creeping and crawling at 9 months. Then the 10 to 12-month range, pulling self to feet, standing alone, walking with help. And those are key identifiers of a particular time parameter in that infancy period, in that birth to 12-month age range. And there's a lot of change in that first year. Obviously, we've gone to smiling to walking. And so those will be key identifiers to you. Don't try to remember every motor skill because you will get very frustrated and not remember anything. So get your key elements down. Also, not only is motor skills developing, but also language development is coming along. Infants vocalize. They do that initially with crying. That is their form of vocalization. Then distinct sounds other than crying start to become evident around 3 to 4 months of age. Also, a key identifier with language development that's coming along appropriately is that the infant will have 2 to 3 additional words other than mama or daddy by 12 months of age. Now, it doesn't mean that you have to understand it, but it's a word, something that that the parent or the family identifies as identifying this word means this for brother or whatever, but they have other words in their vocabulary besides mom and dad. And then developmental stages about how cognition works, what the interests of the child are. We'll focus on Piaget and Erikson. They are the most widely accepted psychosocial development theories that we see used in pediatrics. And in infancy, remember that with Erikson's psychosocial development, we're working with trust and mistrust, which is nothing more than developing a relationship with the caregivers. The cognitive development, which we associate with Piaget, is sensory motor. Everything is reflexive, and that we imitate experiences and try them over and over. A key thing here with infancy is object permanence. This is where, and it occurs around 9 to 10 months of age, that the baby can identify that his self and objects are separate. And the way that this will manifest most likely in a question is caregiver separation anxiety, where the baby has now realized that if mom goes out of a door, she just didn't disappear, and that's okay, and I'll just move to something else. Hey, she's gone, and that's distressing to the baby. And this is going to be important when you talk about hospitalized child, when you see questions about that, anxiety, caregiver separation, and that will start to manifest about 10 months of age. Then play, and this is a sequence, again, that we'll follow through with all the developmental stages. With play, characteristics at different age groups, you see that there's a fairly lengthy list of things that they can do. If you'll note, these kind of go along with their motor skills in what they're able to do and what their interests are. With 0 to 3 months, remember, we're very reflexive and verbal, vocal. So toys that are brightly colored, mobiles, those kind of things, music boxes, anything that's going to stimulate the senses. 4 to 6 months, this is where the baby, remember, is starting to see new experiences, can reach for objects, holding their head up, turning over some. So seeing themselves in the mirror, brightly colored, rattles, things that make noise, and they can manipulate them are good. And then 6 to 12 months, again, imitation is becoming very, very refined. So repeating pleasurable activities, imitating behavior, faces, playing peekaboo, clapping hand games, those kind of things. And their toys, at this point where they have developed some fairly good gross and fine motor skills, they can start to pour things. So playing in sand, large boxes, moving in and out because their motor skills will allow them mobility now, are good choices. But safety is always key when we're talking about play, toys, movement, gross motor skills, to anticipate what the baby's abilities are because they change very rapidly, and to keep their environment safe. So toys at this age need to be very large, no strings. They have a lot of motor skills and abilities, but not a lot of thinking abilities to know about safety. That they should obviously always be supervised, and that toys should not have rough edges. Anything that's small that can be aspirated, just like their nutrition, their toys need to be things that are not easily aspirated. And then our health maintenance or health promotion. By and large, most pediatric patients that you will encounter in your practice are not ill. We're doing wellness. And many of your questions in pediatrics will be based on wellness and health promotion. So health maintenance with this age group is, again, with safety, is keeping them from hurting themselves, getting into trouble because they advanced their motor skills a little bit, but they don't know not to do certain things. And so the environment has to be tightly managed. Also, immunizations. This is a huge way of promoting health and disease prevention. Now let me say something here about the immunization schedule. I know that at some point in your program you were responsible for probably memorizing that schedule. Maybe you've forgotten a few things, or you didn't get it down as well as you would like to back in your program. This would be something that you must do, is to know that table inside and out, because you will see questions about, are immunizations up to date? Is something due? That kind of thing. And if you don't know the immunization schedule, you will not be able to answer the question correctly. But the infancy period is a big time for immunization. We have hepatitis B, diphtheria, tetanus and pertussis, or the DPT, the Hib, all of those. And these immunizations are going to be going from 2, 4, 6 months up through the first year frequently, as you can see from the immunization schedule. So commit those to memory. That is very important. Also, intervention, talking with parents about how to manage the infant after an immunization, that Tylenol can be given, especially for the DPT, because it does make the baby fussy. The DPT does cause a little bit of an elevation in temperature, soreness at the injection site, and makes the baby fussy, so a couple of doses of Tylenol is helpful for that. Also, that the baby will not be immunized if they are ill or have fever. Those are probably the two biggest things that you're likely to see in relation to immunizations, except that you need to know what they are. Another issue with safety, infant restraints. This has been around for so long, it's probably not something that you're not aware of or know. We'll briefly talk about this, that the baby needs to face the rear of the car until he weighs 20 pounds. He has to be in a car seat, never placed in front of an airbag, and the middle rear seat is the safest area for them. Remember, rear facing till they're 20 pounds. Aspiration of foreign objects, again, is another health maintenance or prevention issue that's very big with this age group, because they begin to develop a lot of motor skills and they can get very small little things. Remember, they want to practice, practice, practice anytime they develop a skill. And so little pincer grasp, that's loads of fun to practice, but it's also not good to get whatever we get and put it in our mouth and aspirate it either. So any small items, food, buttons, if there's a sibling with other toys that are not age appropriate, to keep those separated from baby so that they do not aspirate. Along that line, we've talked about health promotion. Health deviations in this age group, that accidents are the leading cause of death in infants under 1 year of age. Falls, suffocation, aspiration, like we've talked about before. Drowning would fall into that as well because of motor skills. That pool is very attractive. Mop buckets, toilet seats, those are all sources of drowning and water sources that could be considered on a question. And also burns, cooking to the back of the stove, those kinds of issues that you're all well aware of. So those are the things that would be focused on in education, and just childproofing that environment and constantly supervising that age group in infancy. Another health deviation that's common to this group with SIDS, or sudden infant death syndrome. We don't know the cause. It is thought to be a cardiorespiratory failure related to brainstem functioning, but the cause is really unknown. The group most associated with this, males 2 to 4 months. Preterm infants are at a major increased risk for this, multiple births as well. We see it during, obviously, sleep times. Winter months have a little bit of an increase. And so educating the caregiver about prevention, things that we have learned through research in sideline and back sleeping, not prone positioning. There will be some infants that are sleeping in the prone position because of medical problems that are directed by the physician to do that. That is not something you're likely to see, even though you've encountered that in practice, so don't put that in there. The standard is sideline or back. That the mattress needs to be firm. They don't need to be in a soft pillow that they can get down in and not be able to come out of and suffocate. And also, we do see a lower incidence of this in the breastfed infant. Now, the next section I'd like to move on to is lifespan development of the toddler. And remember that the toddler is defined as 12 to 36 months of age. That is your toddler age group. Now, their physical characteristics are starting to change quite a bit. They are that little group of kids who have that little pot-bellied, waddly gait, that are very busy. Remember, this is a busy age group. They're into a lot of things. And so if you have anything to remember about the toddler, that they're busy, busy, busy. They're developing motor skills and they're refining them a lot. So that would be something to help jog your memory. Busy toddlers. Their growth rate does slow a bit, and their vital signs are starting to slow. If you noticed where I talked about in the infancy period, we're going to back off everything about 20 beats. 80 to 100 is the normal pulse range. 25 to 35 is the respirations, and your blood pressure average 100 over 70. And so you're just backing down a little bit as the child goes up in age. Nutrition with this age group, they have a little bit of a growth lag, so their calorie count has moved from 120 down to 100 per kilo per day is their need. And they are starting to express an interest in food. They can make preference and choices. Feeding themselves. Remember, toddlers are very independent. They have lots of skills that they're able to use now, and they want to use them. They're also busy, and they don't like to take the time to eat their meals. So promoting with education nutritious snacks and meals, more frequent feedings instead of 3 big meals a day is probably more appropriate for this age group. They do require still a great deal of rest. They're very, very active, but should be sleeping 10 to 12 hours a night with a nap. They start to see a little bit of night fear, but rituals, bedtime stories, those kind of things are helpful to get the child comforted and into bed. And again, with our motor skills, just like we did with the infants, you see there's some age ranges here and some key things that are happening in those, and I'm going to give you the ones that are most likely to be seen. With the 13 to 16-month-old, walking without help and mimicking housework. 16 to 18 months, throwing the ball overhand and removing their clothes. With 2-year-olds, running well and dressing themselves in simple clothing. 2.5 to 3 years, daytime bowel and bladder control. So those are the key things in that toddler age group that I would focus my attention to keep your time span of what can they do, what is expected, what can you be expected to see in teaching, and what's important in your questions, because you'll be given the child's age and what anticipatory guidance might you be needing to give, education about a certain milestone, and so you'll know what needs to be taught. Language development is also coming along very quickly. By 18 months, we have 10 words. Notice that the 2 to 3 word phrases by 2 years of age, we're starting to string along sentences. And they should be able to give you their first and last name by the time they're 2.5 years. Now with the toddler, the psychosocial development focus is autonomy versus shame and doubt. Autonomy meaning, remember, independence. They want to be independent, try new things, and feel good about doing it. They're also very egocentric. They want to do everything their way, when they want to do it, and how they want to do it. And that's a key thing with toddlers. They're busy and they're very self-centered. Cognitive and sensory motor. Objects are a cause of action. That's why they want to manipulate all the objects, the VCR and the TV and everything else. They want to handle everything to see what happens. Okay, that's why we see that. And they're very concrete thinkers. Don't forget that what you say is exactly what it is. There's no abstract thinking with this group. Also, their play. We're coming along with different levels of play. Toddlers are parallel play. They do not share. You have a room of toddlers. They're all side by side playing, but no one's doing the same thing. Okay? They're not sharing. Whoever has it in their hand is who owns it. And however you can get it is their game. Also, their activities. Remember that their motor skills are advancing and becoming much more refined. So gross motor skills are practicing with jungle gyms, push and pull toys, and also the ability to pedal, such as a tricycle, does not come along till about 2.5 to 3 years of age. They can push with their feet with a toy, but pedaling is a gross motor skill that doesn't come along till about 2.5 to 3 years. And of course, their fine motor skills are getting very good. So building blocks, water painting, crayons, all those things are age appropriate for them in any of your anticipatory guidance or talking with your questions. With health maintenance, toilet training is your key thing with this age group, in that achieving potty training or toilet training 18 months to 2 years, and more so the 2-year time span is where you really need to shoot for. They have to have physiological readiness, and we know that that does not happen until at least 18 months of age, to have sphincter control. Also, imitation is always good. This is an age group that responds well to imitating, trying new things, and so imitating with potty chair, that's always good. But remembering that nocturnal potty training really may not be achieved, especially in boys, until age 4 or 5. And that is not considered pathological or problematic. Maybe to the parent, but it is not considered a real problem. Toddlers are very negative, they're very egocentric, they're very busy, and so they need to have a safe environment. They also, the discipline and parameters for that, keeping limits very simple and consistent, because remember, they're very concrete thinkers. They don't have a big attention span, so it has to be very short and sweet and exactly to the point. And as well as safety. I can't reiterate any more how much safety is going to be part of the review for pediatrics with the age spans, and toddlers are very big in that because they are just into everything. So they need supervision in that child-proof environment again. This is also the time span where they will probably turn their car seat around to the front because they've achieved that 20-pound mark. You'll notice there's that immunization schedule again. We're still getting some immunizations. The MMR at 15 months, the Hib again at 15, a DPT and OPV at 18 months, and the chicken pox after 12 months is optional if the parents want to do that, if there has not been disease at that point. Accidents are still our major concern with health deviation. Motor vehicles. Not only are we passengers now that we're concerned about with car seat safety as we've always been, but now this is an age group now that can be pedestrian risk because they're walking, they're busy, They go and do their own thing without any knowledge of safety. Burning, getting into hot water, turning on faucets, reaching the stove, just doing things they don't know that they don't need to be doing. Again, busy, nosy toddlers, drowning, suffocation, aspiration. Again, we see that. Falling, poisonings is a new one that we have added to the list. They're more mobile. The more mobile the child becomes, the more motor skills that they have, the more risky the environment and every aspect of it. So education about poisoning is a likely question, anticipatory guidance type question of what would you say to the parent about this age group and poisoning, that they should have poison control number at the phone, that they should not do anything if they feel that a poisoning has occurred until they contact poison control, have a in-date bottle of syrup of Ipecac, not one that was used with a brother 5 years ago. Be sure it's in date. And locking up cleaners, medications, all these things in a child-proof container behind lock and key. Height, we've learned, doesn't work very well. It's not the height. It's got to be unreachable. So having that Ipecac at home and being in date, that is something that we know has been on the exam too, being sure that it's in date. Moving on to the preschooler, this is the age group that is 3 to 5 years of age. And a way to remember them is that the 4-year-old, the average 4-year-old is 40 pounds and 40 inches. So you have those 3 fours together. A 4-year-old is 40 pounds, 40 inches. They're still growth lagging a little bit. We've gone down to 90 calories. We want to encourage finger foods, nutritious meals. We're getting much more picky about food, even more so than the toddler. Their activity and rest does change. They give up their naps, but they do still sleep 8 to 10 hours a day. This is the peak time that you're likely to see sleep disturbances in relation to nighttime fears. You're likely to see a question with this age group, with the preschooler, that they don't want to go to bed, there's a monster in the closet or under the bed or those kind of things. So night lights, having a bedtime ritual, maybe sitting with the child a few minutes till they drop off to sleep helps this in allaying those fears, and this is a common thing that happens in this age group. Again, we're going to do our motor skills just like we have in our other groups, and I'm going to tell you the key ones. I also want you to note the little box here that I've given you a little age group identifier. I hope that's helpful to you. If you look, the 3, 4, 5 button lace tie, and that kind of goes with some key motor skills with this age group. With at age 3, they can button. At 4, they can lace shoes. And at 5, they can tie them. Another way that I like for you to remember about shoe tying is at 5, preschoolers start kindergarten. They're not with their mom, and there's not enough time for the teacher to tie 20 pairs of shoes. And so they're going to need to know how to tie their shoes to go to school. Okay, we're going to branch out. We're going to go to kindergarten. We've got to know how to do some things for ourselves. So you can kind of remember shoe tying that way. But with the 3-year-olds, they can dress with supervision, pour fluids from pitchers. And this can be problematic, and also it can be a good thing, but they can pour from one container to another. 4-year-olds, hopping and skipping on one foot. This is a key motor skill for that age group. And then with 5-year-olds, walking backwards, printing their name. And that's another one you can kind of relate to kindergarten. It's one of the first things that we do at kindergarten is we learn to write our name on everything. So tying our shoes and writing our name when we're 5 and going to kindergarten is always a good thing. Also with language development, with 3-year-olds, notice how the vocabulary has jumped up to almost 900 words. A key thing with 3-year-olds is they talk constantly whether anyone is really listening. They love to talk. They also have complete sentences. With 4-year-olds, this is where you get the constant questioning. The vocabulary has jumped up tremendously, 1,500 words. Also, they may stutter. They have lots of questions, lots of thoughts, lots of things they want to know, and they get very excited about talking, and they may stutter. This is not considered pathological. It's considered a normal developmental thing at this age group, and so it's not considered pathological. You may see a question about it where the mom is concerned that the child stutters when he gets excited and these kind of things, and it's what they're looking for in the answer is that this is a normal developmental process that will most likely work itself out, but it can be monitored. With 5-year-olds, the key thing here is that the speech can be understood 100% by others. Again, you can also relate this to kindergarten a little bit. We go off to kindergarten, mom's not with us all day, so she can't tie my shoes, I need to be able to write my own name, and everybody needs to be able to understand me because my mom's not with me to translate anymore. Okay, so everybody needs to understand me. Then the developmental stages, initiative versus guilt. Not only are we wanting, our previous age group wanted to try autonomy, try new things, now we're going to initiate it. We're not waiting for the experience to come to us, we're going to initiate it. And we want to feel good about it. With cognitive development, again, our thought patterns and things are very egocentric. Vivid imagination here. This kind of ties in with lots of this talking and questions and imagination all go in together. That's where you get those nighttime fears again with magical thinking. And with socialization with your 3, 4s, and 5s, some key things there. With 3-year-olds, the imaginary friend, they can also separate from their parents fairly easily. The 4s, very bossy and impatient. That's a key one there. They ask lots of questions and they're also very bossy. And then the 5, you notice a drastic change, less rebellious, more responsible. They just seem to really calm down. Again, you can relate that to kindergarten. I can't go into class bossing everybody around. You know, I've got to be able to get along with the group. And so developmentally, I'm getting there and being ready to do that. We've added a new category with this age group with sexuality. By 3 years of age, a child should know that their sex is different than the opposite sex, that masturbation is something that can be seen, it's not considered problematic. Exploring the opposite sex or being sure that everyone's parts are like mine or different than mine is something that's commonly seen, playing doctor, those kind of things. It's not considered a big problem or anything abnormal. It's just a normal way of exploring or finding out new things. And then play. Play is becoming more cooperative to a degree. Obviously, this age group range, lots of talking, lots of questions, very, very busy. So they're going to want to be loud. They socialize a lot during play. And then materials that they like to play with is pretty much limitless now. Their motor skills are fairly refined. They can handle most things. Their imagination, things that will encourage imaginative play are very good here. Dress-up clothes, sandboxes, puzzles, all the writing toys, bicycles, those kind of things. Any art-type activities with Play-Doh, scissors, painting, those kind of things are all very age-appropriate. And then with our health maintenance, again, we're still focusing on safety, maintaining a safe environment. They will, at some point, most likely discontinue their car seat use, usually seen around 4 years. They have to be 40 pounds. And then again, there's that immunization schedule again. Not as many things happening with this age group, though. They get pre-kindergarten booster, 5 years of age, with DPT, the OPV, and the MMR. And these are boosters that will be required for entry into kindergarten. And, of course, any missed immunizations will be caught up at that time. Discipline, again, consistent limit setting, maybe constant too, but consistent limit setting, and timeout for behavior that's inappropriate. One word about timeout, you may very well see questions about behavior limits and timeout, and the parents saying that timeout doesn't work, and they feel they're losing control of discipline and they can't get where they want to go with discipline. What they'll be looking for is that you know that the timeout limit should be no more than 1 minute per year of age. So, for example, a 2-year-old's timeout limit really should be 2 minutes, not 10 minutes. And the mother may be saying, I'm trying to get him to time out for 10 minutes and he's 2. It's developmentally impossible for the child to sit for 10 minutes. And so doing that teaching, so keep that in mind that it should be 1 minute for each year of age. Now with the school-age child, this is the 6 to 12-year-old group. Physical characteristics starting to change. They start into some heavy growth here, growing an inch or two a year, 3 to 7 pounds a year of weight gain, so they're growing significantly. We'll start to see puberty changes earlier in the girls than that 10 to 12 year range, with the boys in the 12 to 14. Vital signs, this is where you get to your normal ranges in adult pattern. As you can see, we've backed on down another 10, 20 beats or breaths per minute, and we're pretty much at the adult range of 60 to 80 beats per minute on the pulse, 18 to 20 on breaths or respirations, and 90 over 110 with a mean of 55 to 60 on your blood pressure. We're starting to see changes with teeth again. We talked about this in infancy, and now with the school ager, we're starting to see changes again, where the baby teeth or primary teeth are starting to come out and the permanent teeth are coming in. That should be completed by 18 years of age, and this is the age group where orthodontia may be needed. But all of the good oral hygiene things that we talked about in the infant group should be applying here, and anything about medication administration, again, protecting the teeth from staining, pediatric patients needing Dilantin, watching good oral hygiene with the gingival hyperplasia, all that would still apply right here to this group. Nutrition is going to be changing tremendously as well, because this age group is now influenced by peers and the media about food, not just the family. Junk food, fast food are going to start to come into play quite a bit here. So obesity, especially if the child is inactive, it becomes a priority of concern. They still need 8 to 10 hours of rest for health maintenance, and that their gross motor skills, like we've talked about before, pretty much is unlimited. And the thing that you can think of now with school agers is not only do they have a full complement of fine and gross motor skills, but they've added wheels to them. Skateboards, bicycles, rollerblades, all the things that are out there. And so we want to be sure that they're wearing safety equipment. That's another health maintenance or anticipatory teaching item that you would want to do. And also focusing that education more to the child or the client than to the parent now, because they're going to be responsible for wearing that equipment and keeping it on. With language development, we see they've mastered all sounds by 7.5 to 8 years of age. They also are starting to use different mediums of communication besides verbalization. They can write, they can read, they can use computers, email. Cursive writing is now part of their complement of skills. So all means or mediums of communication are now available, and their skills make them able to use those mediums. With developmental stages, we're in industry versus inferiority. Industry meaning taking on a project, taking on an activity, completing it to the end, taking pride in what they're doing, and feeling good about that again. We always want to feel good about what we're doing. We're taking an initiative, we're being independent, we're also completing something and feeling good about it now. Cognitive development, we're at concrete operations, classifying, sorting, problem solving, inductive thinking. What would, if this happened, how did that happen, how did we get to this point? They're able to do that. Socializing, at this group they prefer peers of the same sex, boys with boys, girls with girls. And again, positive reward is very helpful with this age group, very important to them. Remember, they want to have industry versus inferiority. They want to see, do things, feel good about them, see them as a positive thing. And then with sexuality, this component that we've added with the last group becomes more important now. With puberty, while the pubescent changes are going to be happening, so now we can kind of add the nursing diagnosis issue of body image here with this age group. Becomes very important. And also, in the latter part of this age group, they start to develop an interest in the opposite sex, and so sexual issues, safe sex, those kind of things may start to become anticipatory guidance questions that you may see here even with this age group. Obviously, they can have cooperative play at this point. That can be a positive thing, and it can also be negative. They can participate in organizations such as Scouts, competitive sport teams, those kinds of things. Also gangs are also part of that. All kinds of games, table games, board games, they can reason those games out. With health maintenance, we're looking at safety, prevention, again, just like as always, immunizations with their MMR booster at 11 to 12 years. And then here, this is a fairly new item, but it is part of the standard that the chickenpox vaccine be given with this age group if they have not had disease. It is recommended. Also, there's problems with this age group, common problems that are quite distressing to parents that you may see, again, education, anticipatory guidance type questions with. Swearing, lying, cheating, stealing, all these things that they're trying. Okay? Not that that is an abnormal event in the age group and how to deal with it, that they're not shocked that the child has done this, but it can be considered a normal thing to try at this age group. Discipline, again, avoiding punitive measures with this age group and being more positive with them because of that industry versus inferiority. And of course, always being consistent. That will be true throughout all the age groups. Stress and coping, this is a new category that we've added in with this age group now, that they have a lot of social pressures at school, a lot of academic pressures many times, and they have a very limited repertoire of coping skills. And so being cognizant of stress-related manifestations, bedwetting, skin rashes, GI disturbances, those kind of things, behavioral changes can be indicative of stress and inability to deal with that stress, and it needs to be investigated. What is the source of that at school or in the peer group? And then, of course, accidents are still very common with this age group and concerning motor vehicles using their seat belts now. Notice that bone breaks are now in here, fractures, because remember, not only do they have their full complement of motor skills, they have added wheels to them. So their risk for bone breaks, head injuries, those kind of things are very, very high. And so wearing that protective gear is a good thing that you're going to see with participatory guidance type questions that they're wearing those. School phobias, fear and dread of school. This goes back to that stress and coping deficiency at this age group. Looking at teacher-child mismatches, fear of failure. Remember, we're in industry versus inferiority, and so failure is not an option with this age group. They want to succeed. And then treating that cause. What is the cause of that? Is it an expectation is too high? Maybe they've entered into a sport or something that they're not really excelling at and they need to try something else. Those kinds of things, but it needs to be looked at. Now, the next section I'd like to move on to is lifespan development of adolescents, which is our last developmental age group. This is the group that's 12 to 18 years of age. Their characteristics are very adult-like as far as their physical features, very individualized, the adolescent period of growth and development. The same group of 15-year-old boys will all be at different physical development levels and emotional level development, same thing with girls, so it's very individualized. The females do mature at a quicker rate than the boys do. That's the main thing to remember here. Also remember that girls start to ovulate and menstruate in this age group, therefore they can become pregnant. So sexual teaching, sex education, safe sex, pregnancy prevention, all those items would be included with this age group. They have a massive growth spurt with adolescents. This is where we see the adolescents eating almost constantly. They have a very high metabolic rate at this time because of the massive amount of growth that's going on. So they do need a good amount of nutrition, high protein, iron, everything for their growth and development. Also, activity and rest. It's not so hard to get them to sleep now as we have seen in the previous groups. They want to sleep all the time. They tire very easily, and this relates back to that very high metabolic rate that they have in their growth that's going on in their body right now, so they do need increased sleep. Motor skills are adult. The other thing that I would add to that is, remember, the adolescent is a risk taker. They are immortal. They will not die. They cannot see into the future. So that can be a problem in some sense. And then their language development is, of course, adult-like. They're very sophisticated in their written and verbal skills. And their developmental stage is identity formation. They are determining who they are. Career goals, sexual orientation, body image, very important issues with this group. They're abstract thinkers. This is a very adult-like group with some decrease in emotional maturity, and coping skills is how you can think about this. Another socialization issue with this age group is emancipation from the family. We want a lot of independence and individuality, and the peer group is the strong influence with this group. Sexuality, again, we're talking about becoming sexually identified with the self, sexual orientation, experimentation with intimate relationships. That can be either heterosexual or homosexual. So common issues that are going to be needed to be addressed with this group: safe sex, HIV transmission, sexually transmitted diseases, adolescent pregnancy, and how to prevent those things, so that good sexual ed teaching. And then accident prevention with health maintenance, focusing on keeping the adolescent and making safe choices, because remember, they're not futuristic, they're immortal in their mind. They cannot die, they cannot be hurt, and so keeping them safe. Increasing independence is the need here with this group. So a disciplinary measure that's very effective with them, that can be discussed with parents, is removing some of the independence or the freedoms that they have and being, again, consistent with it. Stress and coping is a very big aspect of adolescence, and because they have a tremendous amount of pressure with drug use, academics, sports, all kinds of areas. And so along with the pressure to feel belonging to their peer group, these other pressures, that depression is very common. We see runaways, eating disorders, all these things, very common problems. And then health deviations with accidents with motor vehicles. Not only are they passengers, they are also drivers. Firearms, spinal cord injuries, again, from those car accidents, some of the things, the risk-taking behavior because of their immortality. Homicide and suicide, again, still are starting to be seen with this age group. This concludes Section 1, Growth and Development, in the Pediatric Review. In this section, we've reviewed characteristics of development, lifespan development of the infant, the toddler, the preschooler, school-age child, and the adolescent.
Welcome to the question and answer session. Test question logic will help you read and interpret test questions correctly, eliminate distractors, and use critical thinking. Follow these steps as you attempt to answer the questions. First, identify the critical elements in a question, such as keywords, who is the client, what is the issue or problem in the question, and lastly, what is the STEM asking. All questions have 4 options, of which 3 are distractors. It is often easy to eliminate 2 distractors, however, the remaining options often appear equally correct. Next, apply test-taking strategies such as identifying a global response, looking for an options with similar distractors, and lastly, similar words. Next, apply nursing guidelines, Maslow's hierarchy of needs, nursing process, communication theory, and teaching learning theory. If you will follow these strategies and guidelines, you will find answering the questions much easier.
Now, let's analyze and answer a question about the content that we reviewed here. As you see your question here, a local child care center asked the community nurse to lead a program for its child care providers on effective discipline of preschoolers. The guideline that the nurse plans to stress most is use positive reinforcement for good behavior, withdraw privileges for inappropriate behavior, be consistent in enforcing the rules, use timeout for antisocial behavior. Now, when you look at the question, let's pick out some key words, concepts, what do we need to focus on, because many times the questions that you will get will have extraneous information that really mean nothing to answering the question. So we're at a child care center. You are the nurse teaching about discipline of who? Preschoolers. So focus on, get your mind thinking about preschoolers, what are their characteristics, and discipline. So based on that information, which one of these guidelines would we stress the most? So that leads us to believe that all of these guidelines are appropriate, but which is the priority? Which would we stress most? So if you've selected number 3, then you're correct. Being consistent in enforcing the rules. If you'll recall through our discussion, discipline, always consistent with enforcement, was important. Number 1, but let's look at why the others were not correct for this particular question. Positive reinforcement is a good behavior to show better results than the negative. That is true. But thinking of Erikson and their psychosocial development of the preschooler, that is not the one that we would stress the most. Remember, we're looking at the priority or what's the most important. The second option, withdrawing privileges, while that is appropriate, especially for repeated inappropriate behavior, it's still not the priority at this developmental stage. Number 4, using timeout for inappropriate behavior, remembering that 1 minute per age of child, is a very good method. But what is most important is that, remembering with the preschoolers, they're trying to exert independence, doing a lot of limit testing, so being consistent is what should be stressed the most. So if you answered number 3, you were correct.